So اليوم راح نتكلم عن chest pain. Of course, when we encounter a case with chest pain, لازم نفرق, is this chest pain cardiac in origin or not? على افتراض أن this pain is cardiac in origin, the second step is we want to know, is this an acute pain or chronic, or it is an acute pain on top of a chronic on and off chest pain. After that, we have to know about the nature of the pain and the associated symptoms, which will help us a lot in the diagnosis. So let's consider a patient presenting with typical chest pain, which is mainly retrosternal in origin and location, radiating to the arm, associated with nausea, sweating, and the patient is like having some pain, and it comes with exertion, relieved by rest, or sometimes not. And let's say this patient was having a pain that is not relieved by rest. So we will consider this as an MI, or at least we want to rule it out. So definitely we will take the patient to the emergency room, we'll activate the emergency policy and procedure in the clinic, and we will ask for help and start managing the patient. The first thing to do is to act fast and efficient. So we will take the vital signs definitely, to make sure that there are no contraindications for the medication that we will give. Then we should have like brief history while trying to manage and taking the vital signs. We will do ECG to confirm the diagnosis, and of course not having findings in the ECG indicating an MI, but the patient is coming with typical symptoms, this will not let us exclude an MI. So we will consider this an MI until proven otherwise, even if the initial ECG was normal, or at least we are not sure. So let's say this patient is having typical symptoms, we did the ABCDE, we opened a vein for the patient. So we will give the management. One way to remember the management that we are going to give is to remember the medications that we may use. So in the past, the abbreviation MUNA was an abbreviation used to remember the medication that we should give to the patient with an MI. When M was referred to morphine, oxygen, nitroglycerin or GTN, and aspirin. It has been changed nowadays in recent guidelines, and MUNA is not used anymore. For example, we are not giving oxygen for every patient with an MI. We are only giving it when the patient is having reducing saturation of oxygen saturation below normal levels. The other medication that is not used a lot now, and it's used in certain situations and has specific indications, is the morphine. So now we should think of another way, or we should think in another way, rather than the regular MUNA way that we were used. But it's good to have MUNA in mind to remember the medications that are given in a myocardial infarction. But it will not be given in the same order. It will not be given to every patient. So if the patient's saturation was maintained, we will not give oxygen, as we agreed on that. Then we'll start the aspirin, 300 milligram chewable or oral, if no contraindications like hypersensitivity to aspirin or NSAID-induced asthma. The other medication is the GTN. And of course, all of us, anyone who works in primary care or in emergency rooms dealing with MI should know what are the contraindications of GTN. The third medication that we should keep in mind is the morphine, as we said. The morphine's indications are if the patient had 3 doses of GTN with no improvement of the chest pain, or the patient has any of the contraindications of GTN, then we will go to morphine. And why is that? Because there are some studies indicating that the mortality and morbidity increased with the use of morphine in every patient with MI. And it's good to have naloxone in the clinic once you give morphine as an antidote for morphine in case of development of respiratory distress. So we have, of course, to keep the patient calm. We have to put it in upright position. Those are very important things to consider when dealing with an MI. If you have the iStat machine where you can measure the troponin, this is something good to add. Otherwise, this will not change your management. So let's take an example. You have seen a patient with typical chest pain. You're considering MI. You did an ECG that is not, you are not 100% sure about it, or you are sure that this is an MI, but you did the troponin and it was negative. So does that mean that you will not consider referring the patient to the emergency room? The answer is no. You will refer the patient to the emergency room even if the troponin you did in the clinic by an iStat machine that's available in some clinics is negative. Okay, so you'll consider on clinical picture and ECG more than other indications. Of course, there are a few things to consider when we are dealing with a patient with MI also, such as if the patient is having hypotension, which is one of the contraindications for GTN. So like if the systolic is below 90, diastolic below 60, so we will withhold the GTN in this situation. We should look for causes of MI in this case, like severe hypertension or hypertensive emergency that causes the MI, or consequences of the MI, like heart failure, for example. So it is good to take history as much as possible from the patient once the patient is stabilized in the clinic by giving the aspirin and GTN and waiting for the ambulance. Very important thing to consider is writing a proper referral letter to the emergency department and the emergency physician and the secondary care with all the medication that has been prescribed, with the presentation of the patient at the beginning, because he may present with different picture and the pain may be subsiding once transferring the patient there. So proper history with proper complaint, proper signs and symptoms, proper examination findings, and proper medications prescribed in the emergency room is, of course, crucial. The other thing is, don't forget ever to ask the patient to come back to the clinic in order to follow the patient up, especially if the patient is having comorbidities like diabetes, hypertension, hyperlipidemia, which should be considered and taken care of properly in the diabetes or chronic diseases clinic in your clinic. So I think this concludes the talk about MI in a very short period of time. I hope you get the best of it.